to everyone joining us from around the world today. I'm Dr. Ruben Ayala, Chief Policy and Advocacy Officer for Operation Smile. And on behalf of the Global Action for Congenital Conditions, it is my absolute pleasure to welcome you all to today's webinar, Building Stronger Systems for Newborn Screening, Diagnosis, and Management of Congenital Conditions, a WHO framework. This webinar is taking place in support of the newly released WHO framework, Strengthening Capacity for Newborn Screening, Diagnosis, and Management of Birth Defects, a landmark resource designed to help countries strengthen services for early detection, diagnosis, treatment, and long-term care within national health systems. We're deeply grateful to the World Health Organization for its leadership and to the many ministers of health, experts, clinicians, researchers, advocacy organizations, parents, and individuals with lived experience who contributed to this great effort. Together, they have helped create a resource that can accelerate progress towards more equitable and integrated care for children born with congenital conditions. And to all of you in the audience, part of this global community, thank you for joining us today and for your commitment to ensuring that every child has the opportunity to not only survive, but thrive. It is now my great pleasure to introduce our first speaker of the day, Dr. Aisha Mariette da Costa, a leading scientist for newborn health at the World Health Organization's headquarters in Geneva. Dr. da Costa has been the thriving force behind the WHO technical consultation process that culminated in the publication of this framework. Over multiple rounds of global consultations, she brought together ministers of health, clinicians, researchers, civil society organizations, parents, and people living with congenital conditions to ensure that the final product reflected both evidence and real-world experience. Aisha, thank you for your leadership, for your partnership, and for your unwavering commitment to improving outcomes for children and for families around the world. The floor is yours, Aisha.
Thank you, Ruben, for that introduction. So thank you all for joining this webinar from wherever in the world you might be. This marks the release of the WHO's framework on strengthening newborn screening, diagnosis, and management of birth defects in low and middle income countries. Next slide, please. So a child who is born anywhere, including in a difficult or a low income setting, deserves the best healthy start. And birth defects affect newborns every year, millions of newborns every year. Approximately 90% of these children are born in low middle income countries. Yet in these settings, the majority go undetected and untreated, which leads to a silent and inequitable crisis. So why is early detection and screening and early detection important? Early detection prevents irreversible harm. And as practical examples, congenital hypothyroidism causes permanent intellectual disability if untreated and some physical effects as well. Clubfoot can cause lifelong impairment, and untreated hearing leads to developmental delays in speech. The earlier we detect these conditions, the more chance we have of treating them well so that there's very little residual damage. Population-based newborn screening promotes equity, and it reduces long-term impairment, it lowers lifetime care costs, and strengthens health systems as part of universal health coverage. It also supports families who often have to bear much of the burden if the condition is untreated. In Sri Lanka, a low middle-income country with a relatively low infant mortality rate, birth defects account for 40% of infant deaths, illustrating that even health system progress does not automatically solve the birth defects burden. Other countries may not have such a large share of infant mortality contributed by birth defects. Nevertheless, it's important that we look into these. Next slide, please. So why did we act now? Because there is this gap that is growing. Proportional mortality from congenital conditions is rising, both in sub-Saharan Africa and South Asia. And the recent report that came out from the UN on the estimates of child mortality showed that in sub-Saharan Africa, mortality from birth defects has risen from 1 to 4%, and in South Asia, from 8 to 11%. And this means that the large unmeasured burden of morbidity is still there from birth defects, and we have no idea of how large that is. High-income countries have got well-developed programs for decades. Low middle-income countries have not had this possibility as yet. In most cases, there are a few countries that have had that, and we have actually invited these frontrunner countries for this consultation. Therefore, WHO convened this series of consultations to help close that gap for low middle-income countries where 90% of children with birth defects are born. Member states had mandated as part of a World Health Assembly resolution that WHO support countries in this endeavor. Now, if we quickly look at what happens in high-income countries and contrast that with what happens in low middle-income countries, in high-income countries, there are systematic newborn screening programs that are mature, have been running for decades. Every treatment is delivered as a standard of care with the aim of preventing disability before it can even set in. There are good outcomes. Conditions like congenital hypothyroidism are routinely detected and managed at birth. And these are well integrated into national health insurance. Some countries have legislation and surveillance systems. In LMICs, systematic screening, diagnosis, and management services are limited or absent in most of our countries. The majority of birth defect cases go undetected, and treatable conditions then end up causing lifelong harm or even death. Birth defects drive a significant part of child mortality now, which means there's a huge unmeasured morbidity, even as other health indicators continue to improve. In LMICs, often families are saddled with out-of-pocket costs, absent referral pathways, and face huge burdens of stigma, meaning that they require support. So universal newborn screening is actually grounded in equity and social justice, ensuring that all children receive timely diagnosis and care, regardless of their national income. And the WHO consultations aimed to form a country-informed operational framework drawn from front-runner low-middle-income countries so that all countries can plan and implement this service. Next slide, please. So we invited a couple of front-runner countries, low middle-income countries that have programs: Philippines, India, Sri Lanka, Egypt, Uganda, to name a few. And we looked at the main conditions that these countries have focused on. Different countries have focused on different conditions, chosen the different conditions for different reasons, which is documented in the framework. But broadly, the countries have focused on congenital hypothyroidism, congenital heart defects, clubfoot, hearing impairment, sickle cell disease, and orofacial clefts. There are a few others as well, but this is broadly what is being done. Next slide, please. What we could see is that even in low middle income countries, this works. It's not that one has to wait till one has a particular level of socioeconomic development before one starts to look at newborn screening. LMICs across different WHO regions have already shown that systematic universal newborn screening is achievable with political will and the right design. Kerala has had congenital heart disease screening in South India. They have supported about 9,000 children, completed 12,000 plus surgeries for congenital heart defects because they found their infant mortality stagnating, and this helped move the needle on their infant mortality. The Philippines started a program when its infant mortality was quite high, about 34 per thousand, initially restricted to 24 hospitals, but now operating in more than 7,000 hospitals across the country, a country that is really largely islands, doing about 4,600 blood spots every day. Uganda has built up a national sickle cell disease program, leveraging its existing HIV infrastructure. It has tested about 100,000 infants in 2014 when it started and is now operating in more than 100 dedicated clinics across high prevalence areas of the country. Egypt has had its Ministry of Health and Population expand newborn screening services for congenital hypothyroidism, for hearing, through its nationwide newborn care pathway. So this is to say that in many low-income countries, there is a way forward. They have found a way forward within the resources and the feasibility of that health system. Next slide, please. So the WHO framework intends to be a bit of a practical roadmap to help low middle income countries move forward with newborn screening. This has often been a challenge because birth defects are so heterogeneous. Countries are unsure of where to start with, what defects to start with, how many conditions to start with, etc. This framework aims to break this down into blocks and provide a bit of a roadmap. So first step would be to prioritize. And to prioritize just one or a very small set of conditions that are based on your disease burden, the capacity of the health system, what is feasible, what the system can afford. And countries, LMICs that we had at our consultation that had started programs usually began with 1 to about 8 conditions. They did not get overambitious at the beginning. It's important to make a practical small start. The second is feasibility. It's really important to map existing human resources, laboratory capacity, if you're choosing a condition that requires laboratory services, not all do. Referral pathways, what is financing, what kind of data systems do we need against what screening, diagnosis, and management of the prioritized condition requires. So if a country chooses hearing screening, for example, then we need to think about what do we need for as equipment, as human resources, as training to be able to screen for hearing loss. And then what do we require to confirm that diagnosis? And then what is required next to treat? The third block is building the continuum of care. So screening is only an entry point, and we must see it as that, an entry point and not an end in itself. Confirmatory diagnosis, clinical management, rehabilitation, and long-term follow-up must be planned as a connected pathway and not in vertical silos. We must place the baby at the center of newborn screening and see the baby and its family through to all the steps from screening, diagnosis, and management, and not stop just at screening. The last is to strengthen systems, which is a phased scale up aligned with health system readiness, because the health system is also moving at the same time as we are screening. Integrated into national health insurances, registries have been built on the basis of screening programs, data systems for long-term sustainability. Next, please. One thing that is completely non-negotiable is state leadership. Every successful program has this as a shared feature, a government that owns it, funds it, at least partially, if not completely, and commits to it for the long term. It is an important decision for countries to take because this is a long-term program, a long-term initiative. Multi-sectoral partnerships have helped. There have been public-private partnerships that have worked with NGOs, academia, parent groups, other ministries, and so on. Legislation has helped. It's not always been necessary, but there has been a legislation, for example, in the Philippines, where they integrated newborn screening into national health insurance and required that all birthing facilities in the country provide screening as a condition of licensure for childbirth services. There have been few countries that do this. Most countries have managed well without it. So it's not mandatory. Financial equity is central, that state budgets cover screening. It's part of universal health coverage, screening, diagnosis, and the management. Reliance on out-of-pocket payments is inequitable and not really suitable for population-based programs. It makes it more inequitable. Donor support has been helpful in some countries. It has helped complement government funding, but it is really important that when there is another partner, a transition to state ownership must be planned at the outset to ensure sustainability. Otherwise, once the partner withdraws, the program will not be able to work. Next one, please. Families' stigma and the cost of human inaction is huge in the space of birth defects. Behind every statistic or number is actually a family that's navigating stigma, financial strain, and a system that may not have always been designed for them. Placing the experience of families and persons affected has been at the center of the consultations that WHO led. They face social exclusion. Mothers are often disproportionately affected. Stigma deters families from even getting a diagnosis and leads to poorer outcomes for the children. A picture often speaks 1,000 words, and on the screen you see a picture of two children that were born a few years apart, 7 years apart. The boy in the picture is 14 years old, and at the time he was born, there was no newborn screening program. The girl in the picture is 7 years old. And when she was born, there was a screening program that was available in the country. And she was screened, diagnosed with congenital hypothyroidism, and treated. Whereas the boy who was born with congenital hypothyroidism was not. So there is a huge human cost for the family, cost for the society behind these conditions if they are not screened for, picked up, and treated early. Addressing stigma, strengthening family support is crucial. It's not an optional part of this program. It's something that needs to be integral. Next, please. So who is this WHO framework for? It is not directed only to clinicians or specialists. It is for everyone. It is for governments and ministries of health to use this as an operational framework to assess system readiness, set policy, allocate budgets, and legislate if it is deemed appropriate. It is for doctors, nurses, midwives, community health workers who are frontline screeners, sometimes to be able to detect a visible birth defect or an abnormal pulse oximetry reading, which may mean possible congenital heart defect, or to do blood spots. It is for clinicians and specialists, for surgeons, cardiologists, audiologists, geneticists, physiotherapists who will provide the diagnosis and the management and whose capacity must be built and sustained. It is for parents and for families who are empowered by information, peer support, rights-based care to seek early intervention and to advocate for their children. And it is for advocates, civil society, and international partners to be able to hold systems accountable, to fill gaps, and amplify the experience of lived voices. Next, please. So it's important now to act at this point in time. We are starting to see proportional child mortality from birth defects starting to rise even in low middle income countries as these countries make the epidemiological transition. It's important because the sustainable development goals require that no child is left behind. And the WHO framework is grounded in real LMIC program experience from families, from persons affected, and aims to give a practical starting point to LMICs. Countries do not need to wait for perfect conditions. India, Cuba, Brazil, Philippines, Argentina, Egypt, all these countries started at very, very different levels of infant mortality, if you think of infant mortality as a proxy for socioeconomic development. The message is start small, build up state leadership, and invest in the continuum of care. Listen to families and scale up. Every child screened is a child given a chance to a full and healthy life. Next, please. Thank you for listening. Back to you, Ruben.
Thank you so much for such an insightful presentation, so full of content and great examples. So in addition to Isha, we also have a few other experts who today will give us some of their share from their experience, and along with them, we'll share some videos from some specific conditions. So our first story explores congenital hypothyroidism and the power of newborn blood spot screening. And after the video, we're going to be joined by Dr. Carmencita Padilla, who is a professor emeritus at University of the Philippines, Manila, a pediatrician, a geneticist whose leadership helped establish the Philippines as a global example of comprehensive newborn screening and follow-up care. We'll start with the video and then we'll go on to Carmencita.
Janelle and JR were both born with congenital hypothyroidism. It's a condition hidden at birth, where the body doesn't make enough thyroid hormone. Left undetected, it affects a child's learning, development, and growth. A simple screening test in the baby's first days can pick it up. When JR was born, newborn screening wasn't available. When Janelle was born a few years later, she was screened, diagnosed, and cared for early. She grew up healthy, and today, she's an engineer.
In the Philippines, the newborn screening program, led by the Department of Health, gives every baby the best chance to live a healthy life as possible.
A simple test at birth can change the course of a child's life. Every child deserves that chance.
Wow, Carmencita, What an achievement. The Philippines has been unusual in that it is an LMIC, a low-income country, where all babies are screened for a set of conditions at birth. How many babies are screened each year for congenital hypothyroidism, and how is this paid for?
In 2025, we had 1.2 million births. Almost 98% were screened for 29 conditions, including congenital hypothyroidism. The law, the Newborn Screening Act of 2004, states that newborn screening will be a benefit package paid by the government insurance. All hospitals and birthing centers are required to offer newborn screening as part of licensure and accreditation for providing childbirth services.
Oh, that's incredible, Carmencita. So one of the themes of this report is that screening must be linked to care. If we continue to think of congenital hypothyroidism, describe what has helped the Philippines successfully connect screening and diagnosis and referral and treatment.
Well, when the newborn has a positive screen, the baby must be recalled for confirmation. So treatment can be started as soon as possible for those who are confirmed. We have a window of a must treat within 1 to 2 weeks of life. Newborn screening centers have follow-up nurses who contact the hospitals and the birthing centers. So when the baby is confirmed positive for hypothyroidism, a referral is immediately done to a pediatric endocrinologist. And then for long-term care, the baby is monitored at one of 70 newborn screening continuity clinics located in government hospitals across the country. And these clinics facilitate the follow-up with an endocrinologist, either face-to-face or online. The Ministry of Health, the MOH regional offices, assist with patient care, from transportation to assistance or provision of medicine.
Thank you, Carmencita. We just saw this video, but let me just ask you, how is congenital hypothyroidism treated? And is treatment a cure? And what happens if the condition is not picked up through newborn screening, as you say, in the first couple of weeks of life?
Well, the main medical management is really just a simple tablet, a synthetic thyroid hormone, levothyroxine. It is needed to allow the baby's brain to develop normally. Treatment is for life. If not treated, there will be growth stunting and mental impairment. The milestones will be delayed. So a treatable condition will be missed, denying the child the right to a full, healthy life.
Thank you, Carmencita. Based on the Philippines experience for 20 years now, or the last 20 years, what lessons would you share with countries that are working to strengthen newborn screening and early intervention services?
Well, the Philippine Newborn Screening Program is now in its 30th year, and I give you 5 major lessons. Well, first, I recommend starting with 1 or 2 conditions. This gives the program team a chance to develop the framework for implementation, which really spans from education of health professionals, awareness campaign for families, a sample collection, a transport to the laboratory, recall of patients for confirmation, treatment, and monitoring. The second lesson will be systematic data collection must be part of the program, as this will be crucial for policy development. In the Philippines, since we had data from day one, we were able to do a cost-benefit analysis on the 7th year, which is instrumental for legislation. It showed cost savings to the government and the family when implemented on a national scale. Third lesson, a policy from the MOH will help push and expand the program, engaging national, regional, and local levels. Fourth lesson, funding for government is crucial to ensure coverage. And my last lesson will be public and private partnership definitely have a place in different points of implementation, especially in the awareness of the general public and the health professionals.
So many great lessons, Carmencita. What would be your message to policymakers and health leaders about the importance of investing in comprehensive newborn screening programs?
From experience, it is only through government policy and funding can newborn screening achieve universal access, especially in the LMICs.
Yes, country ownership. Carmencita, thank you so much for being with us today. Our next video focuses on Clubfoot, one of the most easily recognized structural birth defects. Early identification of birth can help ensure children receive timely treatment and the opportunity to reach their full potential. Following the video, Deborah Mudariki, who's the Senior Manager for International Education and Clinical Development at the Global Clubfoot Initiative, and also a physiotherapist of over 18 years of experience, will share why early detection and referral matter. Let's go with the video.
ndị na-ekwu nwanne ya ụkwụ ya dị etu nke ya nwanne ya si dị so ya wute m ebe ọ dị too much nnyebe akwa
majuwazi ole otu ha ga-eme ya that time
ndị akpọ mkpọ dị dọkịta otu ụkwụ ahụ dị ọ ga-adịkwa mma na-ekpọrọ ya ala.
Within the first year, we saw 98 patients. That was a huge difference from 1 out of 10 completing to more than 90 out of 98.
Now my leg is straight. I can play with my friend. I can go to school and I can dance with my friend.
Deborah, thank you so much for joining us today. What is clubfoot and why does it occur and how common is it?
Clubfoot is a condition that babies are born with, where one or both feet are turned inward and downward. It won't correct on its own, but the good news is clubfoot is treatable. We still don't know what causes it exactly, but it's important to dispel common myths and make sure people understand that it's not caused by anything the parents did or did not do during pregnancy. Clubfoot is also more common than many people realize, affecting about 1 in every 800 births. That is 200,000 babies born with the deformity each year. The burden is especially high in low and middle income countries where the birth rate is high, but 70 to 80% of babies don't have access to care. This is a very large gap and burden for preventable disability that health systems must address. In India alone, 40,000 babies are born with the deformity every year, and in Nigeria, around 10,000 babies are born with the deformity each year. But unfortunately, most of them are not treated.
Thank you, Deborah. So many questions. I'm going to try to share a few at the same time. So who can identify clubfoot, and why is it important that babies born with clubfoot are identified and treated early? And what happens if the condition is missed or treatment is delayed?
So the good thing with clubfoot is it is usually quite easy to spot at birth. And in most cases, a simple examination of the baby's feet can identify the condition. So midwives, nurses, physicians, and other primary healthcare providers can all play a critical role in recognizing clubfoot. With little training, frontline workers can identify the deformity quickly and help families get connected to treatment as early as possible. When it comes to why it's important to identify it early and treat it early, we understand that timing really matters when it comes to starting clubfoot treatment. When the condition is missed or treatment is delayed, this becomes very difficult to correct. The children may end up requiring major surgery and highly specialized interventions that are simply not available in many countries around the world. Children with untreated or delayed treatment will experience limitations in walking that worsen, along with stigma and reduced participation in activities like school going, employment, and community life. Finding the child with clubfoot is only the first step. Families also need a clear path to treatment so that they can begin the care as soon as possible.
Deborah, maybe you can help us close the section by letting us know how is clubfoot treated, how long does it take to cure, and maybe highlight a few of the, in addition to the human benefit, any economic advantages of early identification and treatment?
Sure. So fortunately, most children with clubfoot can be treated using the Potsenti method. Treatment usually begins with a series of gentle manipulations and casts that gradually move the foot into a corrected position. This takes 4 to 6 weeks. Next is most children can also require a small procedure called a tenotomy, which releases a tight heel tendon and allows the foot to move freely. After this, the children have to wear special clubfoot braces until they are around 4 to 5 years of age to maintain the corrected position and prevent relapse. So we see that when treatment starts early and families stick with the bracing, children grow up walking, running, and playing just like their peers who never had clubfoot. Major surgery is also avoided when treatment starts early. In terms of the benefits to families and the economy at large, we learn that early treatment is one of the most effective investments a health system can make. It prevents disability, avoids expensive interventions later on in life, and reduces the demands on health and social services, enabling children to grow into productive adults who can fully participate in school, work, and community life.
Thank you so much, Deborah. Our next video highlights how newborn screening can help identify congenital heart conditions before complications occur. And after the video, we have Dr. Srihari Nair, who's an assistant surgeon at the Department of Health Services at the government of Kerala, India, and he'll share lessons from his experience improving the lives of so many patients in his country and in his region. Let's go with the video.
People here have known about sickle cell disease for hundreds of years. And unfortunately, those...
I'm so sorry. I think we have a different video. This is a sickle cell, and we would like to welcome Dr. Srihari Nair of congenital hearts.
Every child deserves the chance to Every child deserves the chance to grow up healthy. Yet, around the world, 1 in every 100 babies is born with congenital heart disease, making it one of the most common congenital conditions. Congenital heart disease is a leading cause of death from birth defects and a significant contributor to under 5 mortality, particularly where access to diagnosis and treatment is limited. The journey to saving a child's life begins with early detection. A simple, painless pulse oximetry screening can help identify newborns with critical heart defects before they become life-threatening. An echocardiogram or heart ultrasound allows doctors to see the heart structure and function, providing an accurate diagnosis and helping determine the best course of treatment. For many children, timely transportation and treatment, including pediatric cardiac surgery or catheter-based interventions, can repair or improve heart defects, giving them the opportunity to survive and thrive. Nearly 1 in 4 children born with congenital heart disease will require heart surgery or another cardiac intervention during their first year of life, but millions of children around the world still lack access to the specialized care they need. When countries invest in newborn screening, timely diagnosis, and quality pediatric cardiac care, they transform lives, not only by saving children, but by giving them the opportunity to learn, play, and reach their full potential. With early screening, timely diagnosis, and access to life-saving treatment, children with congenital heart disease can survive, thrive, and look forward to healthy futures, because every child deserves a healthy heart and a healthy future.
We're so happy to have you, Dr. Srihari. I'm going to maybe mix a few questions here for you. Why is screening for congenital heart conditions such an important component of newborn care? And could you tell us, so knowing that screening, diagnosis, and managing congenital heart conditions involve complexity and high intensity resources, why did a low middle income country setting like Kerala decide to focus on congenital heart defects?
Ruben. So screening for congenital heart disease is actually a vital step in ensuring improved newborn survival. Because it is one of the most common congenital birth anomaly, and accounts for at least 1 in 100 birth globally. So some of the critical congenital heart conditions are not obvious at the time of birth. In that case, you need to do a screening using simple tools like pulse oximeter, so that it can be diagnosed and the care pathway is provided at the right time. So that's very important for screening for congenital heart disease. And a state like Kerala went for such a program because in 2016, when we were considering a target for sustainable development goal with regard to infant mortality rate, we found that our infant mortality rate was stagnated around 12 for the last 15 years. And an expert group was asked to review the situation. They found that almost 28% of the infant mortality was contributed due to birth defects. And out of that, almost 60% are due to congenital heart disease. That is one of the reasons why we thought we need to have a comprehensive program for congenital heart disease management. That's the reason the state decided to go for a program, and we built the program.
Dr. Harry, so addressing congenital heart disease implies a complexity of care that includes echo, cardiac surgery, intensive care service for babies. What arrangements has Kerala made that have enabled it to provide this care and really organized through the government?
Yep. It is not the congenital heart disease alone. Actually, we started with managing other newborn conditions like prematurity, birth asphyxia. Along with that, we built a strong program for management of congenital heart disease. We starting with a routine screening for every newborn immediately before the discharge. Using simple tools like pulse oximeter and a cardiovascular system focused physical examination. That is started, and then we expanded the service portion for echocardiography to the level of district level special newborn care unit, which is a part of the tertiary care units. And they were linked to the pediatric cardiac centers. Then the most important part was a strong referral network system supported with a web-based portal, which is developed by the state. And all the available resources in the state, especially with regard to pediatric cardiac surgery and intervention, were pooled through a structured partnership with the private sector. And most importantly, I will believe the thing that the state government decided to go for a strong financing system, reimbursement through the empaneled hospitals, so that none of the families need to take the burden of the cost of care, making the care and the treatment provisions for every child available, or all those with congenital heart disease.
Thank you so much, Dr. Harry. I think so many parents here in the audience, certainly many of us who are here today with you, will think of this image that we have. If you have a child, you will at some point lean your head into and your ear into your child's chest and listen to their heart. What a powerful testament to giving a kid a chance to live a healthy and happy life, what you are all doing. May I please ask you, what are 3 pieces of advice you would have to share with other countries so they can start the same type of care you've delivered in Kerala?
Yeah, the first thing will be broadening the access to newborn screening using the simple tools like pulse oximetry and cardiovascular system focused physical examination. And train your frontline health workers to identify signs and symptoms, and extend the screening beyond the newborn period to the vaccination sessions if possible. The second, I believe, establishing a technology-enabled referral system that will make sure that all the children with critical congenital heart disease or even congenital heart disease are swiftly transferred from where they identify to a center where the cardiac care provisions can be provided. And third, of course, enhancing the capacity through pooling all the resources in your pod, in your region, enable some environment for a private public partnership, so that the care provision is available to all these children, with some focus in mind that there should be a functional, effective financing system, if possible through the government insurance system, that every country should think about.
Thank you so much, Shahar, for such important lessons. Our next video demonstrates how early identification and care for children with sickle cell disease, you got a preview before, changes the course of a child's life. And then following the video, we are going to hear from Dr. Charles Kiyaga, who's a national sickle cell disease leader in the Ministry of Health of Uganda. He'll share his experience in building screening and treatment services for sickle cell disease. Let's go with the video.
People here have known about sickle cell disease for hundreds of years. And unfortunately, those with the disease can die at a young age.
When I was young, we were twins. And my twin sister died at the age of 6. My parents went to the hospital and they told her that I'm a sickle cell patient. And that was the reason why my younger sister died.
Children who are placed on treatment, they have lived better life as compared to children who never knew they have sickle cell disease. Newborn screening is important. Comprehensive treatment for sickle cell disease children is very important.
If we are able to screen people early or children early and find out what they have, we are able to help them with clinical interventions to improve their quality of life and not make them suffer as much as they do.
So before we started newborn screening in Ghana, we knew that about 50% to 80%, 90% of these children don't survive by 5 years of age. And we were quite gratified to say that in the first 10 years of the project, we had lost only 4.5% of the children.
If we have enrolled these babies into the clinic before their 6th month, possibly by 2 months of age, it likely will help them to survive, the complications of the disease.
Me catch from say, mom, no embu on my baby. Me no more on my baby. So was sickle cell patient. Yeah, really brain. I want to say, a funny immune system the year week. You have special attention. You have special attention, man. Only come on.
I love to see the smiles of the babies and the parents, and there's a whole lot of evidence and great work behind those beautiful smiles. Dr. Kiyaga, welcome. Would you mind sharing with us about the progress Uganda has made in the screening and caring for children with sickle cell disease?
Yes, thank you very much for the opportunity to share our experience. The Ugandan journey has been an innovative one, without necessarily funding for sickle cell, but leveraging on existing programs. As we stand now, we have a national coordination desk sitting at the Ministry of Health within the Child Health program, and also in chronic care for the long term. We do conduct newborn screening using through a centralized laboratory, and we have so far tested over 700,000 babies, and we have identified over 52,000, and these ones are being taken care of in over 100 clinics that we have opened across the country. Of course, we started with high burden regions doing targeted screening, and the 52,000 babies that have been identified, 32,000 are already on hydroxyurea. This has provided great relief to families and patients themselves, because the testing and the treatment is being provided free of charge. Now we are working on scaling up the newborn screening from targeted to universal newborn screening.
Dr. Kiyaga, we understand that sickle cell disease screening can be done in one or two ways. Can you actually be at the point of care or via a centralized lab system? And Uganda chose the latter. Why?
Yes, Uganda chose the latter because we already had systems that had been built around that centralized mechanism through the HIV funding. We already had a sample transport system that connects the entire country to a centralized laboratory. We already had a laboratory information system that could be leveraged for sickle cell. So we would start off without necessarily investing in all these systems. And newborn screening is not a testing for the sake of it, but it involves linkage to care and also retention in care. All these systems had already been built alongside the HIV program, that was already running. So our centralized newborn screening laboratory does give us, helps us also to add additional congenital conditions without necessarily having to do a lot of investments. Centralized testing helps us to capture centralized data, which is an epidemiological niche, and the remnant samples can be used for research and surveys, which we store. Centralization optimizes the testing process, improves quality assurance, and also simplifies laboratory logistics.
So interesting. So you actually use systems that have been built and you maximize and amplify them. Wonderful. Well, we know that Uganda has had a number of international partners support at the beginning of the journey. Would you please tell us the role of these partners and the various ways in which they have supported the Ugandan government?
Yes, the partners have been very handy in this journey. Right from when we did the survey, we did not have enough technical expertise and resources, but we got a partner who was willing to walk the journey with us. Along the way, additional partners have come on board, and their major support has been on equipment, reagents, technical support in terms of training for laboratory techniques as well as clinical care. And their support has inspired the government, that is the Ministry of Health, to also find funding for sickle cell disease. Before we did not have a vote, but now we have a vote where we are procuring hydroxyurea and additional support for the program. But this has come out of the inspiration that has been built through the international partnership.
It's wonderful to hear. So you've mixed that with the country ownership. What a great lesson for us all. Thank you so much for being with us today. Well, not all congenital conditions are visible at birth, and hearing impairment can go undetected without screening and have obvious implications in the speech development, language, and overall communication. After the video, we'll hear from Dr. Carolina there, who's a technical lead in the World Health Organization's Ear and Hearing Care Program, an ENT with a public health specialist with a wealth of experience in the topic. She led us to talk to us about the importance of finding and treating these conditions such as hearing impairments very early. Let's go with the video, and we'll go with Dr. Carolina there.
Pavana was born with a hearing impairment. It was picked up through newborn screening and managed early with hearing aids.
It approximately affects 2 to 3 per 1,000 newborns, and if left unaddressed, they limit their capacity of speech and language development. Screening with simple methods helps early detection and timely intervention.
Today, Pavana is in school and she enjoys an active life, playing, dancing, and spending time with her friends. Her hearing impairment does not limit her in any way. Every child deserves that chance.
Thank you so much, Carolina. Welcome. Would you mind telling us how common it is for babies to be born with congenital hearing loss? And are there countries where it's more common? And why does it occur?
Thank you for that question and for the introduction, Ruben. Congenital hearing loss affects about 3 to 4 per 1,000 newborns globally, making it one of the most common conditions detected at birth. However, in some regions like Sub-Saharan Africa and South Asia, rates can reach up to 20 per 1,000 births. And overall, around 80% of children with hearing loss live in low and middle income countries. About 70% of the cases are bilateral and roughly 30% involve profound hearing loss. The higher rates in some settings reflects factors such as higher premature birth rates, maternal infections like rubella, and genetic causes, along with more limited access to newborn screening and preventive services. Importantly, these are systemic and biological factors, so there is no parent to blame, and many causes are preventable or manageable through stronger antenatal care, vaccination, and early detection programs.
And why is it important for low middle income countries to invest in universal newborn screening to detect and manage hearing loss?
Investing in universal newborn hearing screening is critical in low and middle income countries because hearing loss is invisible, not evident at birth, and is very frequent. Around 50% of newborns with hearing loss have no risk factors, meaning that targeting only high-risk infants would miss half of all cases. This is why screening must be universal, not just selective. Without screening, hearing loss is often identified around 2 years old, when delays in speech and language development are already established. The brain needs early sound input to develop and understand oral language. The international recognized 136 rule, screen by 1 month, diagnose by 3 months, and start intervention by 6 months is essential because this is a critical window for brain and language development, and timely intervention allows children to develop communication skills. Beyond the profound impact on the child and their family, untreated hearing loss carries a significant economic cost for countries through increased need of special education, reduced employment opportunities, and loss of productivity. Universal newborn hearing screening is therefore not only a health intervention, but a cost-effective investment in human capital and national development.
And Carolina, if a child is screened and found to have hearing loss, what are the next steps? Will that child be able to live a fully normal life like other children without hearing loss?
Well, very good news at this topic. If a newborn screening test indicates hearing loss, the next step is the confirmation. Remember, screening is not diagnostic, and early intervention following the recommended pathway, screening within the first month, confirmation by 2 to 3 months, and start of treatment no later than 3 to 6 months. Acting within this early window is critical because it allows the child's brain to receive sound during the key period for speech and language development. Delays are not an option. In most cases, children are first fitted with hearing aids, which is a non-surgical and highly effective option for many of them. Children with profound hearing loss will require a cochlear implant, which provide excellent outcomes in this group of age. Key message: there are effective rehabilitation options for all degrees of hearing loss, and when interventions are timely, the results are excellent. Children develop normal speech and language, attend to schools without need of special education, form social relationships, and go on to have full family lives and careers, just like their peers without hearing loss. The best way to ensure early rehabilitation and excellent results is through universal newborn hearing screening. I hope I convinced you about the importance of newborn hearing screening.
Fully convinced, and it's wonderful news that we can address this and give children a wonderful life of opportunity. Thank you so much once again for joining us today. So through today's webinar, we have seen how early detection and timely treatment can open the door to care and lifelong opportunities for children. Our final story will bring a message to life through the experience of a child born with a cleft lip and palate, and it's a powerful reminder that behind every statistic, there is a child, there is a family, and a future that can be changed by acting on the knowledge and the opportunities that we have at our disposal. So let's appreciate the video, and we'll turn it over to Aisha for closing after that.
We come from a very humble background, and economically we are not that able, and we were about to lose hope because the kid was, those stigmatization, the society. When he went for the surgery, that anxiety, you don't know a kid how he'll come. When he came so different. I just wept because my kid is now looking like the other kids. Now he's now in school, he's in grade 2, and I'm very proud about it. And the teachers are saying he's very bright in school. Even when we are doing homework, he's very bright. What I can say about the operation is that it gave him a lift from that kid being stigmatized by the society. If I meet a parent who has a child who has a cleft, I just tell him, your kid is not having, not witchcraft, not juju, not what people say. Don't listen to those stigmatization. Your kid is normal like the other kids. If you have an opportunity for that surgery, go for it.
Well said from a father who obviously loves his child. On behalf of the Global Action on Congenital Conditions and of the audience and of the many professionals who joined in the creation of this wonderful framework, Aisha, thank you. We leave it to you for closing today.
Thank you very much, Ruben. I'd like to acknowledge the Global Alliance for Congenital Conditions for supporting the WHO bring together this webinar. Thank you to everyone who has been such a terrific support along the way that we went to develop this framework, who are probably in this webinar, and if you're not, thank you wherever you are. 5 key messages from the framework to take home with us. One is that every child, regardless of where he or she is born, has the right to a healthy start in life. Birth defects are a major but often overlooked cause of child mortality and disability, particularly in low-middle income countries, and we need to remedy this. Early detection saves lives and prevents lifelong disability, as you saw in the videos that we had in this webinar. Third message, countries do not need to wait for any perfect conditions to be present before starting. We've seen the experiences of many countries. It's documented in the framework that countries have started across varying levels of infant mortality. There isn't any magical number that you have to reach to start. Fourth important message, screening alone is not enough. Screening is not an end in itself. The goal must be continuum of care that links together screening, diagnosis, management, rehabilitation, and long-term follow-up. And the last important factor that I'd like to bring up is political commitment is decisive. Sustainable programs must have government leadership, financing fully or partially from the state, and integration into health systems so that no child is left behind. Thank you all for listening. I realize that there are a number of questions that have come up. We will make an attempt to respond to your questions and send to everybody a link so that you have a recording of this webinar as well for your purposes going forward. Thank you all. Thanks to the team and best greetings from WHO.
Thank you very much.